morning, good afternoon, wherever you are. Welcome to VUKA. VUKA is an online conversation moderated by WACI Health, and it's meant to reach out to civil society, policymakers, government officials, donors, and the infected and affected communities, and everybody who is interested in health. We all want to bring all these partners together with one goal: to discuss how to ensure there's access to health for all. VUKA is a Zulu word meaning rise. It's also a Swahili word meaning jump. So welcome. Today we are here to discuss about tuberculosis. Tuberculosis is one of the leading infectious killer globally. In 2019 alone, according to the World Health Organization report, about 10 million people got infected with tuberculosis. About 1.4 million people lost their lives to this disease. Today, we're here to discuss what do we start to prevent and what we can do to prevent.
There is a problem with your internet.
Sorry about that. With me is a guest from Botswana, probably one of the most experienced people in Africa in TB. Cynthia has over 40 years experience as a nurse, and over and above that, she has 19 years experience in coordination of TB. And currently, she's coordinating partnerships and networks in Botswana. Before I invite Cynthia to tell us more about herself and probably her perspective around TB response in Africa, I want to welcome our virtual participants and reminding that we are live on Facebook, Twitter, and YouTube. Feel free to drop all your questions, your inputs, and your questions, or your answers. No stones unturned as far as TB response is concerned in Africa. Welcome, Cynthia. Can you tell us about your services? Anything I forgot about your profile?
Hi. As you said, I'm Cynthia Kivas. As you said, I have Bachelor of Arts in Nursing Science, and the major subject was Community Health Nursing and Health Service Management. So, as she has said, I have 40 years experience as a nurse and 19 years coordinating TB program in the district, and I have experience of coordinating TB program in the district and in towns. So I worked in the hospitals, and my last years, for about 8 years, I was working as coordinating multi-drug resistant TB in the hospital, which is in the city of Gaborone. At present, I'm working at Victor's Global Botswana organization as a partnership and TB network coordinator. Over to you.
Thank you, Cynthia. So tell us, why TB? Why did you choose to just engage yourself in TB response?
As we have said about my CV or whatever I have mentioned to you, I had interest working with the community, like dealing with patients who has infectious disease like TB. The first time when I joined my nursing, I was working in rural areas, and now where I was working, there was a lot of TB cases, and I developed experience. I developed interest in the TB program, because as I was working alone in the facilities, at the same time working in the community. At the times when the patients are not in the facility, I'll go to the community to do case finding, looking for the cases in the village, because I could have found that there is a lot of TB in that community. And then we'll investigate those cases when they come to the facilities. And I was even able to diagnose those cases through the signs and symptoms and the results of the sputum when they come, and put the patients on treatment. So I developed that interest because there was a lot of TB cases in that community. Over to you, Evelyn.
Thank you. 19 years in TB response. Probably you have some experience that none of us have because, yeah, 19 years has been a long time. Can you probably tell us the difference there has been in TB response 10 years ago or when you started and now, as far as technology is concerned, as far as how governments respond to TB is concerned, and as far as political commitment is concerned, 19 years ago and now, where has been the difference?
There is a lot of difference because when I started the on TB program, the duration of treatment was taking a year. When I started, it was taking a year. And then it kept on changing, and there was a lot of drugs which one patient used to take about 8 to 10 drugs. I mean, 18 to 20 drugs when we add the supportive treatments. And then later on, everything changed because of the improvement of the studies. And then we were able to change that treatment to 6 months. And even later on, the number of tablets ended up reducing. And at the same time, even the investigations, when we started, we used to use ESR. The people were collected blood, and then there was some HIV test which was done so that you can diagnose a patient. And then the technology changed, and later on we were able to use the sputum. And recently, they were using the gene expect machine, which is able to pick up resistance immediately so that the patient cannot just delay. And at the same time, even the system of diagnosing patient now started to improve, because immediately when you collect the sputum and then the sputum is sent for gene expect, you'll be able to know whether this patient is a multi-drug resistant case or just a drug sensitive case. And it's now easier for you to take action immediately, because previously you used to take the sputum and the patient takes a long time. You have to send for culture, which will take a long time. However, it doesn't mean that when you have done the gene expect, you cannot send the specimen for culture. These are the improvements. And then the government had been committed to this because the government was able to order the drugs for us. And then every time when the system changes, or every time when the guidelines changes, WHO changes the guideline, the country is able to act on that, like to buy the gene expect machines, as they have bought the gene expect machine. They were bought by the government because now WHO changed to another system of this. Every time when there is a new system, the government does that. Even the drugs, the government was buying drugs. We never had any problems of drugs. The government was able to buy the drugs for that. At present, for multi-drug resistant TB also, the government has taken action to change to short regimen, and then people and be able to buy the new drugs which WHO wants us to follow their policies or guidelines.
Thank you. Clearly, we can see a lot has changed from diagnosis, treatment, political commitment, reduced number of drugs. We can see so much has been put into this. And before I come to talk about how research has contributed to this improvement in technology, I would want to first let's talk about the gaps. When you look at the current TB response, what gaps do you think exist, or do you feel exist, that hinder access to TB services for TB patients?
Yeah, recently insufficient funds for the resources. Even if I said the government is able to assist us, but the funds are not enough for the resources. And at the same time, there is this multitasking of responsible people in the facilities. As I've said, funds is a problem, because if you don't have enough staff, one nurse will be given multitask. And there is that knowledge between the patient, the community, and the clinician. As you know, every time when the nurses are trained, there are still new nurses coming in, and they still need some information, they still need some knowledge. And at the same time, before they are being empowered with the knowledge, you'll find that there is a gap between the patient, the community, and the nurse, even the doctors. You'll find that sometimes new doctors come before they are being trained and be able to know about the disease. They still see the patient, and there are some gaps. So the patient lacks some information there and there after seeing the patient. However, we are doing a lot because thereafter the government gives us money to keep on training these desks to try to help that. There is also insufficient case finding. Insufficient case finding at present is because that is shortage of staff. At the same time, if there is shortage of staff, case finding is not very enough. That's why we think it's better to have the TB ambassadors in the community so that they can be able to assist us in case finding. And also the stigma and the side effects are these ones which may hinder the access to care. If somebody has a stigma and then they will feel that they cannot go there, and some side effects. And prioritization of COVID-19. COVID-19 has taken almost everything. So at the entry point, people are tested for COVID-19, but they are not screened for TB because resources seems to have been shifted more, or focus is more on COVID-19 to attend to that. And as I've said, because of that stigma, some of the people don't even go to the facility because now they feel when they get to the facility, they will be checked for COVID-19. They still have that stigma. Some of the people, they don't want to be checked for that. Over to you.
Thank you, Cynthia. I want to remind again our online fans that are live on Facebook, YouTube, and Twitter. Remember to drop your inputs, your questions, and any comments around TB and on what Cynthia has shared with us. Cynthia, with all these years of experience, probably there are those incidences that have stuck in you because probably they were very challenging. I would want you to share with us a case that that was very challenging in your work as a TB coordinator. Just share with us one experience that you've not forgotten.
There was a case that was a multi-drug resistant case. So she was a female, and then she was put on treatment, and then she built resistant to the first lines of MDR, and later on she built resistant to the last drugs of MDR. So this poor patient has been put on treatment. There was nothing we can do. And later on, when he was done an X-ray, we realized that this poor patient is now, one of his lungs was collapsed. And since the country now is not able to do that, we started to organize for this patient, to refer the patient to South Africa. It was really pathetic because she was a married woman with some children. And then when I saw that this patient is not improving, it was really hurting to me. It was really a sad story for somebody who has built resistance to all the drugs which we can assist this patient on. So fortunate enough, this patient, after we have negotiated, tried all this, because it wanted some money for us to refer the patient to South Africa. After we have made all the negotiations, and then the government, fortunate enough, was able to assist that this patient has to go to South Africa to be done an operation of that lung. And it was successful. We're happy because it was successful. It was just crossing the fingers, knowing that when this patient, whether the operation is going to be successful. When he came back, this patient, when he came back, he was better. And I can tell you that even at this present moment, I was communicating with that patient. She's working somewhere else as a healthcare worker. She's a family. She has some children. She's now okay after that. That was roughly 2012, if not 2013, when that was done, that operation. But she's okay at this present moment. But it was our saving sleepless night when thinking of this young girl losing her life when he was on treatment, and we couldn't help her. Not we couldn't help her, but there was nothing we can do because he has built resistance to the drugs.
Thank you. Thank you. That's a demonstration that amid all these challenges, there is hope. TB can be cured. There's always, though the challenge, TB can be cured. Now, you have brought out quite a number of challenges, and you having all these years of experience, of course, you have proposed solutions to the things you have raised. The problem of resources, stigma, human resource, and case finding. In about 1 minute, what recommendations would you make to policymakers, to the government, on how they can address the solutions to the problems that you have raised?
Firstly, I think it's very, very important to have a knowledge workout program in the community to empower, more especially for the health promoters, to empower the community about TB so that they can have they can know a lot about TB in the community so that they can even be able to bring themselves to the facility. And also to strengthen case finding in the community, because if case finding in the community is done, we'll be able to pick up the cases, and be able to pick up the cases will be aligned with the UNHLM targets, because now the cases will increase and we'll be able to pick up. And also community mobilization, which is sustainable, not just to go to the community when there is an activity to teach the community. It has to be an ongoing thing so that we can even remind them, update them about the new events, and combine some TB activities with COVID-19. This is one of the recommendations, to combine TB activities with COVID-19, because as I've said previously, you'll find that COVID-19, most of the resources has been gone there, so that when one goes into the community, dealing something about community at the same of COVID-19, at the same time, he can look into the issue of TB. And there have to be a deep research on TB disease related to COVID-19, so that we can see the progress and the complications. Maybe at present we are just saying most of the people are dying of COVID-19. Maybe there is TB behind. So we have to do a research on this. The government has to do a research on this, the relationship between TB and COVID-19.
Thank you.
Over
Cynthia. Thank you. Thank you so much. You've mentioned about the need for more research and the need for integrating TB.
Can't hear you. I can't hear you, Evelyn.
Just one message you do want the presidents to get regarding TB response in Africa in 20 seconds.
In 20 seconds. So what I will tell our country president is that it's very, very important that we have to put some resources on TB so that we can pick those cases in the community to try to align with the targets, with the UNHLM targets, which he committed himself on, so that we can try to bridge the gaps on TB. Even the treatment for TB, we have to be able to be monitored properly. And some funds, as I have said, there have to be some funds which has to be aligned to the TB program, so that we can end up being able to have enough resources for the people to go to the community, the healthcare workers in the facility. Most of it at present, there is that COVID-19. So that at least when we are looking at COVID-19, at the same time, we must not lose these cases. And because if we don't monitor these TB cases properly, we'll end up having increased multi-drug resistant cases in the community. Thank you.
Thank you so much. That was a message to the president. More money allocated to TB. We need to engage more communities in TB response. Thank you so much, Cynthia, for sharing your perspective with TB response. VUKA show will continue. We need to have these conversations more frequently until we get down to the bottom of why are we still dying from incurable and preventable diseases. We must stop these needless deaths. Thank you so much, online participants, for joining us. We look forward for the next show. Thank you.